patch pump, and by doing this, he promoted that diabetes is you can have a normal life and type 1 diabetes. What's special about this guy? He is, I've never actually heard about him. He's a famous freestyle swimmer, Olympic winner. He won one Olympiad. Following that, he was diagnosed with diabetes. So what normally people will think that that's the end of your career. It wasn't for him. He was diagnosed with diabetes, and then he won Olympiad in freestyle swimming twice again. Do we know this lady? So can you see what she has here? So I can show you, I have the same one as well. So moving on, what I wanted to talk to you. So this is diabetes, just as reminder. Oh. Reminder for everyone, actually, what are the symptoms of diabetes? I'm sure everybody knows it's people feel tired, feel thirsty, go to the toilet a lot. They get these infections they don't want to be, they cannot treat the infection, cannot shift the infection. They have blurry vision. But what's something that we don't really see much anymore because of the current treatments is this fruity breath, the ketone breath, which was a stigma that was associated with diabetes before we were able to treat it. Oh, okay. Yeah. So talking about diabetes, just wanted to start from the history of diabetes. So diabetes has been present among people since the human existed. The first mentioning was in Egyptian Eberus papyrus, which was mentioning the disease where flesh is liquefied into urine. And that was 1500 BC. So you can see it was recognized as a disease long time ago. Indian physicians were calling it madhumeha, honey urine, because the ants were attracted to the urine of the people, and that was also associated with a stigma. So if somebody has passed urine somewhere and the ants were gathering, they were sick. That was not really a nice thing. First time the term diabetes was used was actually 100 years AD, when it was first in Greek, meant siphon, because these people, as we said, disease where flesh is liquefied into urine. But the first description of diabetes as a disease was mentioned by Persian physician Avicenna, who in Canon of Medicine described the disease, described that it's associated with diabetic gangrene, and recommended a mixture of seeds, lupin, fenugreek, and some other ones. But we have to understand that all of this was disease that was happening to children, to young people. It was not really happening to older people. And once diagnosed, it was a death sentence. And it was just happening all around, and people couldn't do it. They didn't understand whether they can do anything to prevent it. It was scary. It was scary, and it was a death sentence. And that was unfortunately, this was happening for long time until Dr. Oskar Minkowski in 1889 put some light into why we get diabetes. So what Dr. Minkowski did at Strasbourg University with colleague Joseph von Mary, there was already some suggestions that possibly diabetes could be linked to pancreas. So what they did, they took the pancreas out of the dog. And what they found is that after removal of the pancreas, dogs get diabetes. It starts sometime after the operation and will persist for weeks continuously until their death. This was the first time when humans understood that diabetes is linked to pancreas. Talking about Dr. Minkowski, he was an eminent doctor. His brother was Herbert Minkowski, who was a teacher of Einstein. And what's interesting, he died early of pneumonia, but he was apparently really, Einstein really looked upon his brother, Dr. Minkowski. In regards to Oskar was born Lithuanian Jewish origin in Lithuania, studied medicine, and was trying to become a professor, but somehow it was very difficult for him. He was nominated for Nobel Prize 6 times. but never got it. And finally became a professor of Uniwersytet Wrocławski, which was not really the place that kind of you wanted to be a professor. And that's the initial paper that was published in 1889. Following that, things got faster. Then the idea was born on 31st of October, 1920. We are moving to Canada. Frederick Banting, young surgeon practicing in Canada and preparing a presentation. As all proper doctors, he's working, oh, sorry, that's not the right one. Go back. Sorry, I've forgotten that I don't have a pointer. So as proper doctor, he's working at 2 a.m. as all the doctors prepare the presentations the night before and reading lots of different papers. And he had eureka moment. He was preparing about this pancreas. Yes, it's causing diabetes. So why don't we take this pancreas and isolate the internal secretions of the pancreas and see whether we can inject it back to the dog that we took off and help with the diabetes. So these are his original notes that he made on that night at 2 a.m. And following that, he went to meet Professor John MacLeod, he was a professor at Toronto University. He was working on carbohydrates, and he presented his research plan. I don't know if he had to write grants. I'm not entirely sure how it worked at the time. But Professor MacLeod was interested, said, fine, you have a summer, gave him an assistant, Charles Best, and said, good luck, go for it. So this is the lab that they were working, and obviously they were working on dogs. And before I tell you how exactly what they were doing, I wanted to mention that summer of 1921 was an important year. Why? Because a young girl called Dorothy Crowfoot, who was initially born in Egypt, but moved to London for further education, as one of the girls, as it was not very common for girls to study chemistry, joined, sorry, I just keep forgetting and pressing, that's Dorothy there at the back of the class. She joined the class in a Sir John Lehman school and was learning chemistry. She was very, very keen to learn. And that's her, Dorothy Crowfoot. It reminds me of the memory test we do for patients. So I tell you about all these ladies, and I want you to remember, and I will test your knowledge later. The same summer in Bronx in New York, Rosalind Sussman Yalow was born. Okay, and I will come back to these ladies, but it was the same summer as Frederick Banting and Charles Best were working in Canada, working on the extracts from the dog pancreas. And that's what they were doing. So they were taking a dog, removing the pancreas, and isolating the cells of the Langerhans from the pancreas. It was purifying and liquidizing, filtering. The dog was developing diabetes, as Dr. Minkowski proven. What they were then doing, they were injecting back the solution back into the dog, and the dog was treated successfully. The first dog was, they started first treatment in November 1921. The dog was called Marjorie. The dog was successfully treated. The dog lived much longer than any other dogs. Unfortunately, what they were struggling with abscesses, because the extra it was very difficult to purify it. So they were struggling with the purification. And the person who was helping them was the biochemist James Collip. So James Collip joined their team, and they were working really hard to try to purify. As I mentioned earlier, diabetes was a death sentence. We had plenty of children like that who were dying. Parent of Leonard Thompson, who was 14 and weighed 30 kilograms, and before they brought him for this experiment, he lived on grapefruit, small amount of meat, and vegetables that had been boiled 3 times. As you can see, there was no rationale. People were guessing. It's like the fenugreek and just some herbs. He was also given whiskey on occasion to numb his constant hunger. It was a death sentence. His parents agreed for him to be taken for this experiment, and he was injected with thick brown extract from dog pancreas on 11th of January 1962. That's why this January we had a big anniversary as 100 years when insulin was first injected into human. Unfortunately, it was so impure that it caused allergic reaction and an abscess at the injection site. But biochemist James Collip, Dr. Collip, he really didn't give up, and he was working day and night to try to purify it. And 12 days later, on 23rd of January, the more purified extract was injected again, and this time the result was amazing. The blood glucose fell from 28.8 to 6.7, but most important, the ketones were eliminated. So this fruity breath associated with diabetes, it was eliminated. Insulin had saved his life. And this is the original observation. So you can see this is all drawn on a special paper with graphs, and that's how it used to look like. Now looks slightly different. Leonardson died age 26 from pneumonia. Whether that was linked or not, difficult to say, but it certainly saved his life and lived much longer than he would have normally. So these are the important people in the discovery of insulin in 1921. Frederick Banting, surgeon; Charles Best, summer student; Professor MacLeod at the University of Toronto; and James Collip, biochemist, who was purifying insulin. And we cannot forget about Marjorie. But only two of them, as life is not fair, were awarded Nobel Prize in physiology or medicine in 1923, and that was Frederick Banting and John MacLeod for discovery of insulin. And that was the first Nobel Prize for diabetes. I will tell you about more Nobel Prizes. One disease, so many Nobel Prizes. Because it was such a huge demand, because suddenly everybody wanted insulin, very quickly the patent was sold to pharmaceutical company, and the first one was Eli Lilly, which actually I didn't know myself because I thought Novo Nordisk was the biggest, but no, it was Eli Lilly, who began selling insulin called Iletin, and but please have a look how it looks. It's all brown and but it was saving lives. It was saving lives, and that's the copy of the first contract signed in July 1922, allowing Eli Lilly to start making it, and that's how the factories look like. So you can see they were initially, of course, they were not dogs. They quickly moved to pig and cow insulin, and it was just so they were located usually next to the places when they were killed. So they were just taking the pancreas and liquidizing and purifying and creating and extracting insulin. So which one is going to get diabetes? These are medical students, young doctors in Aberdeen. Which one is going to get diabetes? Any of them, isn't it? But the one who actually got it was this boy, and he became the father of British diabetes. Robin Daniel Lawrence, was born in November 1892 in Aberdeen. He studied medicine and was trained to become an ENT surgeon in King's College. But then he was diagnosed with diabetes in 1920, age 28. What did it mean to him? Death sentence. 1920, I don't know even if the idea was born, if Frederick Banting had the idea then, but he was 28. That was it for R.D. Lawrence. He was so upset, he stopped studying, he moved to Italy to slowly die in Florence in a nice climate, and where he moved with the family. But because he had some friends in college before he was when he was still studying, and when the insulin became available in 1923 to everyone, it was very quickly adopted by King's College, and they called him, come back from Italy. We'll give you this magic injection. We have the treatment. So R.D. Lawrence came back from Italy, and he got his first injection on 31st of May 1923. And it worked. And he became appointed chemical pathologist, then slowly became a physician in charge of diabetic department at King's. And he's the founder of British Diabetology. He is the founder of British Diabetic Association, which is Diabetes UK. He died age 76. the interesting thing, I've forgotten to mention how he was diagnosed with diabetes. So he was, during his training, they were doing, as ENT surgeon, they were doing a procedure and something kind of got into his eye. And he had infection that he just couldn't shift. Then he was admitted to hospital for this eye infection, and then he was diagnosed with diabetes. And that's how it was usually diagnosed, with the infections that were not shifting. Another question, which of this is double Nobel Prize winner? Not the girl, not the smiley, is this young boy. Uh, so we are moving on. So just to kind of summarize what we know. So we know it's pancreas, we know it's insulin, but actually we don't know what's inside this brown liquid. So my husband, Jim, was asking, what do you mean they didn't know? I said, well, I don't think they knew because they kept extracting it. It was a liquid, injecting, it worked. So, but nobody knew what was the structure inside. So this boy in the middle was called Frederick Sanger, and he enjoyed biochemistry, studied biochemistry, and in 1955, he determined the amino sequence of insulin. So he found out that the insulin actually consists of two chains, alpha chain, beta chain, which are connected with these sulfur bonds. How he found out, I'll tell you in a minute, but it's now a special message for Dorota, who was asking me recently during our walk in the park. What do we know about how do we measure insulin production? So this is not known at the time. This is something like additional, but I think it's easier to see this on the picture. So this has not been known until recently, but this is pancreas, and that's how the insulin is made. So you can see that insulin is made as a proinsulin, long peptide. So we have a beta chain, C chain, and alpha chain. To become active, it's cut in these two places, and it's bonded here, and what we have left is the C peptide. So C peptide is more stable, and we can measure it in the blood, and it's a marker of exogenous insulin production. Please, this is something not discovered at the time, but this is something because we are looking at the structure, so I thought that would be very relevant, and that's how it's made. C-peptide, the function of C-peptide is not fully understood if there is any function, but insulin is very quickly cleared from the system. So C-peptide is much more stable, and you can detect it, and it's a marker of endogenous insulin production. So coming back to our Frederick Sanger in 1955 in Cambridge, he got a Nobel Prize, so second Nobel Prize for diabetes. In chemistry, 1958, awarded to Frederick Sanger for his work on the structure of proteins, especially that of insulin. And how he did it? So it was a peptide. So what he was doing, was available lots of different enzymes to cut the protein into smaller parts. So he was cutting them into first each amino acid. So then he found out what amino acids we have there. Then he was cutting them into special things. So it's like a puzzle that he was doing, and they were all cutting. So he was seeing which amino acids are coming up and what combinations. And it's called partition chromatography. And this technique he used to define the structure of insulin and further proteins. Interestingly, he used the same technique, because why is he double Nobel Prize winner? What's his second Nobel Prize? For the structure of DNA. And that's exactly the same technique he used. Maybe not the same, because it was a few years later, but the same principle. He was chopping the DNA into smaller parts and looking what's there and how it kind of binds together. So a few years passed, and well, actually the fact that insulin was creating crystals was known from the beginning, because it would crystallize. I think that's why we are shaking. People used to have to shake insulin, because it will form these crystals. So we can see this nice kind of 6-side crystals. But nobody understood how it's made, again. So protein X-ray crystallography was a technique discovered in 60s. And what was happening is that there would be an X-ray machine sending this, X-rays around these protein sample crystals. They were all eating picture on film. From this, by changing, I don't fully understand this, but they would be able to create a 3D model of various proteins. Who do you think has discovered this? A test. I told you about this person already. Ah, very good, very good. Dorothy Crowfoot Hodgkin, because he already got married, and she received the Nobel Prize in 1964, so a third Nobel Prize for diabetes, because she described the 3D structure of insulin using protein. She developed the technique X-ray crystallography and described the structure of insulin. And how this, so what does it mean, this insulin hexamers, the crystals? Normally we have two chains. The insulin creates dimers and then creates hexamers. When they're kind of all together, that's why we have these crystals. So we know now pretty much everything about the insulin, how it's the amino acids, which creates the 3D structure. So the next thing we were wondering, how does it really go around our body? So the person who kind of progressed our knowledge in this was the second lady who was born in summer 1921, Rosalind Yalow. So she linked insulin with this radioactive iodine, and that allowed her to develop a technique called radioimmunoassay, which is actually still used to characterize various metabolisms of various hormones of various things in the body, because it allows you to see the clearance, how long it stays in the body, and it was very important for the kind of pharmacokinetics of the insulin. And she was the one actually that helped us to understand that the difference between type 1 and type 2 diabetes. The type 1 is there is no insulin, and type 2 that is caused by the body, by the resistance. So we have plenty of insulin, it's not used properly, and we call it insulin resistance. And she got a Nobel Prize in 1977 for the discovery of radioimmunoassay. And I think that was the last Nobel Prize for diabetes. Now we're just going to briefly talk about how do we use this insulin to treat diabetes. The first textbook was written by this gentleman who we already talked about, Dr. R.D. Lawrence. So he published this book in 1925, so very quickly, 2 years after he was already started his treatment. And there is a couple of statements I wanted to read from this book. Falińska, Diabetic Death would have been a more suitable title for such a book as this than The Diabetic Life. I make no apology to doctors for writing a combined book they paid, for the latter invariably come to know a great deal about their illness. And that was the first thing to make us realize that diabetes is something that the patients need to manage, and we are there only to help them. That's why the education, the empowerment, which now we're putting a lot of importance on. It was already mentioned on 1925 by Dr. Lawrence. So life for patients with diabetes before insulin, as I said, it was a little condition with little hope of survival. Most of the people were dying. As I mentioned earlier, the treatment consisted of, here it's another example of canned asparagus, cabbage, tea or coffee, cooked onions, raw celery, and they were all developing complications and slowly dying of them. But the early treatment after insulin, although people were living, the life was not easy. Their school, education, work, their daily activities were all affected. They were unable to have a completely normal life, as I showed you initially, that now I think people with type 1 diabetes really can achieve anything. Before, it was not easy. It was poor understanding. They were still developing complications. They had low esteem. They had to carry this insulin with them. They had to check the glucose. Just a quick look at insulin development. So we were together at this time in 1920s, when this was the extract of the pancreas from whatever it says, from the cows, from pigs. And you can see it was long time they were just purifying, attaching different things, but not much really was happening until 1980s, when the human insulin, which I show you in a minute, was introduced. And now we are not only having human insulin, but we are talking about rapid acting and long acting. And that's the concept that was introduced not long ago. So animals' insulin, they were very similar to human insulin. This was again the picture, and just look at the color and look at the sediment. And that's what the people had to inject. And what was the main problem? It was still a foreign protein. So people were developing antibodies and allergic reactions. So very often you had to move from bovine to pork one, and it's kind of moving there and back. And it was all continuing this chromatographic purification throughout the time. But the breakthrough happened in 1982 when, again, Eli Lilly, which I didn't know about, I thought it was all Novo Nordisk. Eli Lilly developed the first human insulin. And again, in 1982, after all discoveries of DNA, they were able to isolate insulin gene from the human cell and test it into a plasmid, in a kind of recombinant plasmid, and made this E. coli bacteria, a transgenic bacteria, and they would just make them to make a normal human insulin, which then was taken and put into vials and used for humans. That was the breakthrough. The first insulin is Humulin. I think we still know Humulin I, Humulin M3. So this is still the same insulin as was discovered in 1982. As I mentioned earlier, now, at this stage, we are all talking about this rapid-acting insulins, which have an onset as soon as possible, and also about the longer-acting insulins, because we want to inject insulin. We are currently doing a trial for insulin that will be able to inject once a week, just to give the background. So the results are very, very promising. The number of units is quite scary, because you need to inject 100 units. So the first time we were like, oh, everybody was watching, oh my gosh, because you have to calculate the 7 days requirement. So it was 100 units, but patients survived, and they are happy and enjoying. So we talked about the insulin. I'm now going to talk a bit more about how we deliver insulin. Because as you know, initially it was syringes, needles, and that's how it was starting. So it was all this insulin, the syringes, the first pack of this disposable glass syringes. Otherwise, people had to boil them, boil needles, boil syringes. The pumps, the idea of a pump when you can infuse the insulin continuously was started in 1970s. But it was not really until another 20 years that the pumps were kind of doable. The first Novo pen, and I have some pens to have a look there, if people want to have a look, was introduced in the 80s. And here it's a big area, and I wanted to talk about this movement, We Are Not Waiting, which started in 2013. So insulin pens, there are some pens here, if anybody wants to have a look. Yeah, you pass them through. So there are some needles, if anybody wants to attach them, and you can try to inject it, how it's kind of injections. You can try to inject the dial. If anybody has not tried and has the desire or interest to do it, and this is, don't worry, there is no insulin. You need a needle at the end, and that's the needle, so you can, so this is the traditional pens that I brought, but now the new technology is this smart pens. So what is smart pen? It's linking with your phone, it's linking with your Apple Watch, it's telling you, please don't forget to take insulin, you have taken insulin, knows that you have taken insulin. So for us, the compliance, because it knows that you have taken insulin, because Big Brother is watching everything. So it's a big thing now, although, it's possibly, some people still don't like pumps and want the pens, but this is all undershadowed by the insulin pumps. So this was the first insulin pumps from 70s. You can see this was no go. This was no go. No one is going to carry anything. And it took long, long time until they changed the size to what you can see here, or what you have seen on Kate Moss's daughter, Oleg, which was a patch pump. I realized that I don't have a picture, but you can see this is this small thing and I've forgotten, I meant to borrow some of them from work. So it is slightly smaller than a phone, and it's connected through some tube under the skin. And so this is the feather pump, which means that there is a pump from which you can actually press the buttons and inject, and it's connected with a needle going under the skin, which is kind of with a small tubing. So this is the one type pump. The other one is a patch pump, which you can see is just literally a pump, and it's like a white thing. That's what she had on the leg. This one, you don't really press anything. You regulate from your phone. So you can, for example, have a dinner, take your phone. So nobody needs to know you have diabetes, because you just take your phone and, okay, I'm texting someone, but actually I'm injecting some insulin because I am going to have a dinner in this restaurant. So that's how the pumps are looking now. Glucose monitoring. Again, I brought some glucose monitors for people to try. If anybody wants to take them home, they're more than welcome. They are near expiry date, so I just ask our diabetes nurses to give them to me. To really manage your diabetes, you have to do it 8 times a day. Well, I tried because I always try to do things, to check things. It's so painful. I just cannot imagine how. But I suppose you don't have a choice. So you just have to do it. So again, the next breakthrough is this flash and continuous glucose monitoring. So this was made by Abbott. It's called flash because it checks the glucose. It checks the glucose every couple of minutes. So it's in principle, it's not continuous, but it doesn't really matter. Every couple of minutes is good enough. And the other thing is that, if I can just put it, so what you need to do is, so I have one attached to me. I'm not diabetic, I just did it for today. And what you do, so the main thing you have to, sorry. This does not send the data continuously. What I need to do, I need to get my phone, sorry. And I need to scan it. And that's what my glucose now. Yeah. So it doesn't transmit it automatically. You can buy some attachments that will transfer it automatically, and that's why it's this group we are not waiting, which I tell you about. But that's how it is now, the crystal. So you have to touch it. You have to touch it to get the reading. Yeah. Sorry, just let me. Just getting undressed. The one on the left is called Dexcom. On the left, right. It's called Dexcom, and the main difference is continuous, which is a bit more frequent. That's not important, but it sends the data automatically to the phone. So that's the kind of main benefit. Although Librace now also has the ones which send it, but initially that was the main difference. And Dexcom, the main thing, although Libre now also has alarms, the Dexcom, the main difference was it had alarms, so it would alarm people that the glucose is very low or very high. So we have a pump, we have a glucose meter, which is now our technology. What do we want? What's our ultimate aim? To have artificial pancreas. So people have been working on artificial pancreas since 70s with all these huge pumps and, but the main problem with everything was the algorithm, because we can check the glucose, we have the pump, but the algorithm that will tell the pump how much insulin to inject, that was, I don't know, it was just impossible to develop. It's not that I know, I'm not a software writer or program writer. But when we had all of these Dexcoms and pumps and everything, there was a group called We Are Not Waiting, because everything, of course, when you have a commercial companies, everything has to go from approvals, safety, and it takes years. So they were not waiting. And they started this DIY treatment. So if your parents were software developer, they would grab some battery, Raspberry Pi, pump. It had to be older versions of the pump that you can actually make some changes. So the older versions on eBay go very expensive, because people used to buy them to make this DIY treatments. So Night Scout was a kind of special, which would take the data from the Dexcom and analyze them, and that would help you to and people would, it's like a self-help, you will kind of make the software make for you. So you kind of take 6 months to create your own algorithm. And it was for free, available. You could just join the group. And if you wanted, they will take you through this. It would be a group called We Are Not Waiting on Facebook and Twitter. And they're still there and still available. And there is certain pumps work with Apple, certain pumps work with Android. So it's a all whole algorithm. As doctors, we were not really allowed to support this, although everybody was like, so we were, but they were experts. We were not. I was not able to tell them what to change, because actually people who they were talking to were the people from the group. We are not waiting. They had conferences. Rise of the machines was one of the one of the kind of meetings that they were talking, and people were talking. So it's usually parents and the younger children that were doing this. And so that was started, I think, 2013. So now, and our trust is trialing it, we have commercial closed loop systems. So this is the pump. So that's what we have. It's this Dexcom, which is checking the glucose. And here it's the important thing that transmits to the pump. And this is what I was talking about, is she had just a patch pump, but here you have the cable going into this kind of plastic needle, infusion set, pump, and it's the link. And this is the main problem, is this control algorithm. This is the brain of all this artificial pancreas, and it's the one that is so difficult to develop. So currently we are trialing there is a big trial organized by NHS England, and it's finishing actually very soon in April. We started our patients, onboarded our patients in September last year, and we have amazing results. You have 4 main companies. The funny thing was, so it's a Medtronic, we have Dana, we have Tandem. Dana is using the algorithm by Cambridge, developed by Cambridge. So Cambridge developed just their own algorithm. So they use the Dexcom that you heard about, and then Dana pumps. And the interesting thing, there was this Medram. Medram was a Chinese company who said, you don't need to buy our equipment, we'll give them for free to try for us. So a lot of trust, kind of, oh gosh, yes, free, let's get it, let's try it, cannot be bad. Disaster. All our meetings, like a progress meetings, we haven't used Medram, so we are just mainly Medtronic. We have Medtronic, we have Cambridge APS, and we have Tandem. So Medtronic's beautiful, working really, really well. Cambridge APS, we were excited about, because they were the place that they developed. The pump you've seen was started in Cambridge. So we thought, gosh, you've been working for many years on this. You must have it, the right algorithm. Not as good as Medtronic. And Tandem just works a bit different. I'm not going to bore you how it works on this, but Medram, we haven't used. It's absolute disaster, not connecting over, so people run either high or low, because this is what you switch off. You just kind of go and it's all just does this insulin for you. You still need to tell them when you are eating, because the algorithm cannot just catch up, doesn't know what's happening, why why the glucose is going so high. But otherwise, everything is done completely automatically. So the last thing I just wanted to say, this is an interesting paper published by one of my colleagues, because everybody knows this word cloud. So what they've done is they asked people who lived with diabetes over 50 years. So people who were getting in diabetes, we give them medals if you have been. So people who got the medals, received medals for living with diabetes for over 50, 60, or 70 years. And young adults. And this is what people who lived with diabetes over 50 years said. So what is it? Hospital, Dr. Lawrence, glass syringes, large needle, surgical spirit. So this is the words that they were using. Strict diet, treated positive slice of bread, extra, you can read extra rations during the war, reagent tables, likely die early, loss of sight. And that's what Life with Diabetes 2001. Annoying, fast-acting, CGM, looping. So looping is when we have the looping. When you have a closed loop, it's called looping. We are not waiting, manageable. How reliable, so everything is reliable. We are talking how reliable are these new systems. You can just look yourself. Fast-acting insulin, DIY, obviously, because it's the DIY systems. And I think that would be it. I have, especially on request for Dorota, if anybody is interested, new nice guidelines for type 2 diabetes because Dorota wanted to talk about that. And I'm happy to talk about that, or we can finish. So thank you very much for listening. Yes, this is, I hope you enjoyed the run through of the history of insulin. How much? Reservoir. It's constantly, you set it up for 1 unit an hour. Like a reserve. So yes, so you have inside the, I forgot to bring them. There is like a, it's a pump and there is like a vial. So like you have a vial in a pen. So it's in this pump, small pump, and you're just constantly infusing it. And obviously you have 100 units and you need to change the vial in the pump, depend how much units you need. So the patch pumps, they are very attractive, but they only have forgotten how many units. So if you are needing a lot of units of insulin, you have to change it every day. So it's usually for people, so you can see she's young, slim, she probably needs 20 units of insulin a day because she's probably not eating much, as you can see. So she's probably needs, so for her, this 100 units or whatever units will last her a few days. But it's like a pump infusion. So you change only the cartridge. So the pump, the mechanism of a pump is just slowly infusing through this slow tube and which goes under the skin.
I've got a question about the "We Are Not Waiting" movement because presumably, if that's a big community online and they're hacking the devices themselves, presumably they gathered quite a lot of quite useful data.
Absolutely.
So the question
Absolutely.
is that data got another question about the Freestyle Libre. They were in short supply at some point. Is that correct?
I think
Or
they
they're
were at
readily
some point, but
available?
no, it's not anymore. I think it's yeah,
Because I have patients who
because
are
everybody
interested.
wanted to buy.
Yeah,
Yeah.
it's who are interested, who are either pre-diabetic or
Mm.
just healthy and
Yeah,
just
yeah,
want to
yeah.
check
Well, that's how I have it in
the
mine.
glucose response to certain food,
Yes.
and rather than relying on glycemic index. What's the cost of the Freestyle Libre?
So it's £50 for a sensor for 2 weeks. And before you had to have a reader. Now I don't have a reader. I just upload it up on the phone and just scan it, and it works. If you've seen, it works very well. Let's see what's my, and the benefit, you can really scan as much as you want. Sorry, just let's see what's my glucose now. Check glucose. 6.8. I'm clearly stressed.
So what's the latest on, or has this sort of died a death, the pancreatic islet transplantation? Is that moving any further forward?
So the main problem is it is a transplantation.
Yeah.
So if it is a transplantation, then you need to take immunosuppressants. And I think that's the main thing. So the question is, because we now have all this amazing technology, would you rather take immunosuppression because it's a transplantation, or would you just use all this technology and have fun with all this, attaching different things to yourself? I think most of the people will say they probably will have the technology. But it's not completely, because what you can do, you can have the kind of like a more, if you can, the work is now on the islet cells that are kind of not immunogenic, if you know what I'm saying. So you don't have to take that. Then yes, but it's not available.
And sorry, one other question. So I've got one patient, and I think there is a literature on this, but I'm not entirely au fait with it. And you may have come across this, who've done very well with immunotherapy for cancer, but the side effect they got is type 1 diabetes. And there's some suggestion that there's a link there
Checkpoint
between
inhibitors.
yeah. So
yes,
how
yeah.
well I've got one patient who should have been dead 4 years ago with a really aggressive eye melanoma in the liver, and he got this within 4 months of treatment.
Yeah.
And so you send them off to the endocrinologist and so on. But there is a literature on that, but I don't know if it's understood why these patients do so well with this biomarker of type 1 diabetes.
So it is not only type 1 diabetes, it's all the autoimmune diseases. So all the immunotherapies are bringing lots of patients to us. Because they're all developing, and we work closely with Agnieszka on that. So recently we have done even an analysis of the data by one of the medical students, looking at how many. So we have, I think most recently, a couple of weeks ago, I saw a patient who is your patient with a kidney cancer. She had a thyroid, she had a cortisol, and now developed type 1 diabetes. Why they are developing? Well, I think it is in the same group. It's autoimmune. It's autoimmune. Well, we have seen quite a few. We have seen quite a few. I think we have at least 3 or 4 in our cohort who developed it after initiation of immunotherapy. So it's not that rare. We have a lot of hypophysitis, a lot of adrenalitis, loads of thyroids. Thyroid is very, very common. Why? I think there was this idea to collect the blood of these people before you start them and create this bank to have a look what exactly is happening. But I mean, the way I understood is that immunotherapies are just directing the cells, that they are just start attacking, destroying the thyroid, destroying the causing hypophysitis, causing the islet cells the destruction, as the kind of the same origin as autoimmune type 1 diabetes. That's what I think is I don't think it's any other mechanism other than immune system.
But there's a link with prognosis. Some of these other ones you get, they don't really link with very good prognosis. Type 1 seems to particularly bode well for a prognostic outlook.
Oh, is it? Oh, okay. Oh, no, I didn't know. No, no, no. No, but that's an interesting, yes. I mean, we have 3 or 4. So they are better responding to the cancer, you mean? Yeah. Yes.
That doesn't necessarily link so well
With the prognosis of the
seems to be
so you want to get it. You want to get it.
it's quite rare, I mean,
Yeah.
I've seen maybe 2. I've treated a lot of patients.
Mm.
So it's not that common, but when they get it, they seem to do. I mean, they've got survival in years.
Wow.
I don't know if that's
Okay.
more
No, but that's a very interesting. I mean, we have a couple of patients. The last one I've seen, she had some. You are giving her some more stuff, this lady, and she doesn't. She doesn't seem to be doing very well from the. She has metastasis, and I think it's all moving on. So I don't know.
Just sorry, one other question.
Yeah.
So the people who get type 1 diabetes in their 50s or later on middle age, Theresa May, I think,
Yeah.
is there anything specific about that age group?
No, so we don't think this. No, we don't think this anymore. We just think it's the same. We just think it's the same as for the younger children. We don't think it's any different. So before you had this late onset, now we don't. It's just type 1, type 2, and then obviously the genetics. So MODIS or type 3C when the pancreas, obviously, when you have the damage of the pancreas surgically or any other.
Okay, thank you. Great talk. Thank you very much. There have been some reports about the association of new type 1 cases with COVID-19.
Yes. Well, I don't know. So interestingly, our pediatric team, because I do transition clinic, they definitely notice higher numbers. I think there is lots of speculation. I don't know what's the answer. But it was noted. Yeah. So the COVID so new diagnosis in children, that was one thing. But generally, when you have COVID, you're given lots of steroids. So that was unmasking loads of diabetes, because people, obviously, when you get steroids, that makes you more insulin resistant. But that sounds like a very interesting case. So with C-peptide measurement, you have to be very careful that you are not given any insulin. Because if you are given insulin, then you are not going to make any yourself. So sometimes you just have to, and C-peptide is still not the easiest test to measure.
Yes? So can I ask you a question about this insulin which is injected every week? Because that's really interesting, because I understand it's extremely long acting and that's fine. But then it's not like your every day is exactly the same. So you might eat on a different time, different amount of food, or your sugar surely it's not.
But it's the basal only. It's the basal.
I
For
see,
eating is the. Oh yeah, you
okay.
still need to inject the other one. But the
understand.
benefit is for people who are nursing homes. So the district nurses can go, or people at home. So the district nurse that goes needs to inject. So they just inject once a day. For our young type 1s who don't want to inject, if we just grab them once a week somewhere, and then inject them, then we know they wouldn't be admitted with DKA. So that's the kind of our main excitement about this. So for people who just don't normally take the insulin.
Chciałam zapytać jeszcze naszych uczestników na Zoomie, czy ktoś z Państwa ma pytanie do dr Falińskiej? Czy jeszcze z naszej grupy tutaj? Jeszcze jedno?
So asking maybe something more sort of from a routine clinical practice, is there any specific scenarios in which you would stop long-acting insulin on admission to hospital for perioperative stop? Yeah.
Well, first of all, you should never stop long-acting
That's what
insulin.
I argue with my diabetic nurses all the time, but they don't listen to me. So maybe a consultant will.
Okay. No, well, I mean, it's difficult. So, I mean, for type 1s, one of the things you should never do is to stop their background insulin. So that's very, very important. Never stop. Even if they're admitted with DKA, and you're doing the DKA infusions, you must continue the long-acting insulin. Type 2s, it's a different story. So maybe. No. It's we argue the same, that don't stop, then stop insulin. Obviously, pumps. It's another thing. Because you will be getting more and more people on these pumps. So again, pumps need to continue. You cannot stop the pumps. All the people with pumps, they should have at home. So if there is a problem with a pump, they should all have the insulin at home and should know very quickly. It's like an emergency protocol for them. If something wrong with the pump, disconnect the pump, inject the insulin. And everybody has it prepared by diabetic nurses. So everybody will be different how much to inject. But don't just disconnect the pump and forget about it. Yes, definitely. Never stop the insulin. Yeah. Anything else?
Thank you very much. Thank you so much, Agnieszka, for really, really interesting overview of insulin and treatment of diabetes. Thank you. I just wanted to say, jeżeli ktoś by chciał uzyskać tak zwany certificate of attendance, to proszę przeskanować sobie ten QR code i wyskakuje na telefonie krótki kwestionariusz, parę pytań do odpowiedzenia i certyfikaty będą wysłane do Państwa poprzez e-maila. Także bardzo łatwy sposób, który został zadesignowany przez naszą koleżankę Martinę Leczycką, która niestety dzisiaj nie mogła przyjść tutaj do nas dołączyć. Także bardzo, bardzo łatwo i bardzo szybko. Chciałam kilka spraw organizacyjnych, które chciałam Państwu w tej chwili przedstawić i później jeszcze chcielibyśmy poruszyć sprawę Ukrainy, która jest wszystkim na pewno bardzo bliska. Więc jeżeli chodzi o plany naszego związku, chciałam wspomnieć, że nasz związek przygotował program mentoringowy dla członków związku. Opis programu znajduje się na naszej stronie internetowej, także bardzo proszę, żeby Państwo zaznajomić, co oferujemy. Wszystko jest bardzo ładnie opisane na naszej stronie. Przepraszam. Oficjalne otwarcie programu mentoringowego odbędzie się w sobotę 30 kwietnia, proszę zapamiętać tę datę, w Ambasadzie Rzeczypospolitej. Serdecznie zapraszamy. Zaproszenie do Państwa prawdopodobnie już zostało wysłane i proszę o zgłaszanie swojego uczestnictwa. Będzie to spotkanie również towarzyskie, połączone z małą częścią artystyczną i kolacją, także serdecznie wszystkich zapraszamy do Ambasady 30 kwietnia. Tutaj detale są, ale również zostały do Państwa wysłane poprzez e-maila. Mamy również... Lista, tak, no będziemy musieli podać listę uczestników do ambasady, także bardzo prosimy zgłaszać się imiennie. 21 maja odbędzie się już 2 razy przekładany bal polskich lekarzy. Bal będzie w Roehampton Club i bilety już w zasadzie można kupić poprzez kliknięcie naszego ogłoszenia w tym rogu, gdzie można również zapłacić za bilety. Bardzo serdecznie zapraszamy. Planujemy dużo ciekawych rzeczy na ten bal i mamy nadzieję, że Państwo do nas dołączą ze swoimi partnerami, żonami i mężami. Szykuje się dobra zabawa. Przy okazji również będziemy zbierać datki na Medical Aid from Poland Fund, którego prezesem jest pani dr Laskiewicz, tutaj siedząca, ale przeznaczenie funduszy, które zbierzemy w czasie tego balu, będzie na pomoc uchodźcom z Ukrainy, więc taki mamy plan. Chciałam wspomnieć o jeszcze jednym spotkaniu naukowym, które planujemy na czerwiec. 12 czerwca tutaj w Saloniku odbędzie się następne spotkanie naukowe. Wykładowcą będzie profesor Peter Dziewulski, który jest chirurgiem plastycznym i wygłosi wykład na temat nowoczesnego leczenia oparzeń. Także to zaproszenie też do Państwa zostanie w najbliższym czasie wysłane. Chciałam również powiedzieć, że pan doktor Bartłomiej Zych, który tutaj dzisiaj do nas po raz pierwszy przyszedł, zgodził się również. Panie doktorze, proszę się przedstawić. Pan doktor jest kardiochirurgiem, który pracuje w Royal Brompton and Harrowfield Hospital i robi przeszczepy płuc i serca. Zgodził się wygłosić wykład na temat właśnie tego swojej pracy ze swoją żoną Agnieszką. Także bardzo jesteśmy zadowoleni, że pan doktor będzie mógł tutaj nam również przedstawić swoją pracę i co pan robi w Royal Brompton.
No, jak już pani doktor mnie zapowiedziała, nazywam się Bartłomiej Zych. Pierwszą część swojej kariery odbyłem w Polsce, w Śląskim Centrum Chorób Serca w Zabrzu. Miałem okazję pracować z panem profesorem Religą, który był moim pierwszym szefem. No i w 2014 roku, w 2008 roku przyjechałem razem z żoną na rok do Harrowfield Hospital. No i tak jakoś zostaliśmy. W trakcie swojej pracy, szczególnie w ostatnich latach, sporo się zmieniło w transplantologii narządu klatki piersiowej. Jest mnóstwo nowych, ciekawych inicjatyw. No i z przyjemnością zgodziłem się
Bardzo dziękujemy.
Na to, że pod koniec roku bodajże z tego, co
Znaczy,
będzie
myślimy
wkrótce,
we wrześniu, jeszcze data będzie do ustalenia, ale bardzo cieszymy się,
żeby przedstawić Państwu taki, nie chciałbym, żeby to był jakiś taki stricte naukowy wykład, ale pewien rodzaj takiego overview, co nowego w transplantacjach narządu klatki piersiowej, w opiece nad dawcą, w organ procurement, co nowego się wydarzyło przez ostatnie powiedzmy 10 lat. Bo to w naszej medycynie rzeczy postępują nie tak szybko, jakbyśmy chcieli. Niestety lata trwają badania i o tym chciałbym Państwu opowiedzieć.
Przypuszczam, że będzie bardzo ciekawy wykład, także bardzo się cieszymy.
Dziękuję serdecznie. Ja się zajmuję mechanicznym wspomaganiem krążenia długo- i krótkoterminowym i prawdopodobnie o tym będę mówić.
Dziękuję bardzo. Datę potwierdzimy, przypuszczam, niedługo, ale musimy jeszcze ustalić. Także dziękuję ślicznie. To na tyle o naszych planach najbliższych. Chciałam teraz przejść i wspomnieć, bo trudno rzeczywiście nie wspomnieć tego, sytuacji na Ukrainie. Wszyscy jesteśmy dogłębnie poruszeni tym, co się dzieje na Ukrainie. Tragedia jest. Bardzo dużo uchodźców, jak wszyscy wiemy, w tej chwili przebywa w Polsce. Jest mnóstwo organizacji charytatywnych, które pomagają. Zanim powiem dokładnie o tym, co się dzieje, doktor Kościesza prosiła, żeby wspomnieć na temat organizacji, która nazywa się Uniters, która zaopatruje uchodźców ukraińskich w leki i środki pierwszej pomocy. Inicjatywa nazywa się Medykamenty. Elu, czy chciałabyś może przedstawić to szybciutko? Doktor Ela Kościesza, która jest...
Drogie koleżanki i koledzy, ja tak postaram się bardzo króciutko powiedzieć, skąd o tym się dowiedziałam przez syna, który jest w Polsce, niedoszły medyk, aktualnie filmowiec. Jego przygoda z Ukrainą zaczęła się w czasie Majdanu, kiedy bez naszej wiedzy i zgody pojechał najpierw do Lwowa, a potem wylądował w Kijowie. No i od tego czasu ma, powiedzmy, znajomości i przyjaźnie zawarte z ludźmi, którzy wtedy tam uczestniczyli w Majdanie i teraz oczywiście w czasie wojny odnowił i jest w kontakcie z tymi ludźmi, którzy organizują pomoc z Polski na Ukrainę, głównie do Lwowa najpierw, a potem rozprowadzają to. Nazywają się United Volunteers i to jest organizacja, która no ma jak gdyby swoje te założenia takie, że ta część tej organizacji przekazuje głównie medykamenty, czyli leki, środki pierwszej takiej no, potrzeby, apteczki, też kamizelki ochronne, nie sprzęt medyczny, tak jak wywiązała się tutaj konwersacja z kolegami, którzy akurat w tym uczestniczą i są zaangażowani i bardzo im to dobrze idzie i może mogą powiedzieć więcej na ten temat. Ja chciałabym tylko poruszyć taką kwestię, ponieważ rozmawiałam i z Dorotą, i z dr Laskiewicz. Uważam, że my ja uważam osobiście, jako organizacja Polish Medical Association, o której wiem, że nie jest organizacją charytatywną i nie mamy, powiedzmy, jakichś wielkich zasobów pieniędzy, ale powiedzmy w takiej sytuacji, jaka jest, wypadałoby nam przekazać jakąś sumę na ten cel. Teraz jak to zrobimy, to będzie do decyzji zarządu i członków, ale mam taką propozycję, która też mi się w pewnym sensie urodziła w czasie tych naszych rozmów. Czy może moglibyśmy przez związek zaapelować do członków o, powiedzmy, wsparcie finansowe i wtedy my jako związek, nie z funduszu naszego związkowego, tylko z tego, co zbierzemy, przekażemy te fundusze właśnie na ten cel. Teraz chciałabym z pozwoleniem Doroty przekazać znowu pałeczkę doktorowi Zychowi, którym okazało się, że są bardzo zaangażowani i robią dużo więcej niż no, ja wspomniałam. I ta pomoc idzie i jest bardzo logistycznie dobrze rozwiązana i jeżeli moglibyśmy się też jakoś w to zaangażować, to chyba by było no, tylko z pożytkiem i z dużą pomocą, która jest potrzebna, konieczna, niezbędna, żeby dalej mogli się i bronić, i walczyć, i przetrwać. Także jeżeli mogę, Dorotka, to przekażę, dobrze?
Ja nie byłam akurat w tej konwersacji, ale bardzo proszę powiedzieć słówko na ten temat.
Ja pozwolę sobie przekazać mikrofon osobie, która jest znacznie bardziej zaangażowana, znaczy Agnieszce. Ja pomagam, a ona jest...
Więc Poprosiliśmy nasz też, oboje pracujemy dla Royal Brompton Harefield Trust, który jest part of St. Thomas and Guy's and St. Thomas. Poprosiliśmy naszego CFO, czy chcieliby donować część przynajmniej rzeczy, które mamy w magazynach. I oni się zgodzili, o dziwo. Zgodzili się i stąd tu uzyskaliśmy olbrzymie zasoby. Pierwotnie było 110 palet sprzętu medycznego, przeróżnych materiałów opatrunkowych, przeróżnych chirurgicznych rzeczy. Do tego dołączyły się szpitale, inne szpitale w Southwest, then North Now. Udało nam się zorganizować bardzo fajną logistykę. Mamy kilka ścieżek logistycznych, mamy ścieżkę lądową, którą zajmuje się SEWA, a potem PD Ward i po stronie ukraińskiej jest to archidiecezja lwowska, która skonwertowała swoje wszystkie kościoły na magazyny i w ten sposób mają dostęp do tych nawet najmniejszych parafii i mogą do najmniejszych szpitali to przekazywać, więc jest bardzo skuteczna. Mamy też taką szybką ścieżkę, bo Wizz Air ofiarował nam sloty w swoich codziennych lotach do Polski. W związku z tym te rzeczy, które są najbardziej emergency, jesteśmy w stanie tą drogą, a potem przez firmę logistyczną Fakro do Lwowa, do tej centrali przekazywać. Jak rozmawiałyśmy, okazuje się, że pracujemy właściwie prawdopodobnie w bardzo podobnym środowisku, bo syn pani doktor prawdopodobnie współpracuje z tymi samymi ludźmi w Lwowie i w tej chwili chcielibyśmy uruchomić takie pakiety takie trauma packs. Już mamy skompletowane wszystkie sterylne części opatrunku i dezynfektanty. Natomiast tutaj właśnie z tymi lekami jest cały czas problem, ponieważ jeszcze cały czas jesteśmy w konwersacji z Agencją Rezerw Strategicznych w Polsce, która była w stanie nam pomóc przy tranzycie tych leków, które by mogły w tym trauma pack się znajdować. Natomiast ja nie wiem, jak rozwiązać sytuację, jeżeli ktoś ma jakiś pomysł. My w tej chwili zaczynamy konwersacje z Big Pharma, z celowymi listami, żeby dali nam chemostatyki, antybiotyki, leki przeciwbólowe, insulina, generalnie wszystko, co jest możliwe. Myślimy też o konwersacji z prawdopodobnie aptekami, które mają leki, które są bardzo blisko końca terminu ważności. Oni też mają leki, które są zwracane z domów opieki, z nursing homes. Czy te leki mogłyby być donowane, ale nie wiem, czy to jest możliwe, tu widzę nie. A mogę poprosić o twój numer telefonu, żebyśmy mogli sobie... Aha, nie jesteś. Aha, okej.
Ja słyszałam dokładnie to samo, że dlatego tych leków nie można używać drugi raz, bo oni nie wiedzą w jakich warunkach i po prostu może nie działać.
Okej, dobrze. I... Czyli insulina na przykład. Prawda? Zgadzam się. I to robimy, nie wiem, jak możemy nawiązać współpracę z...
Ja myślę, że prywatnie porozmawiamy sobie na ten temat. Na pewno chcielibyśmy w jakiś sposób dołączyć i poprzeć to, co robicie zdecydowanie. Ja chciałam powiedzieć, że w piątek miałam przyjemność uczestniczyć w Polonijnej Rady Konsultacyjnej w ambasadzie, gdzie była dyskusja właściwie bardzo długa na temat, jak pomagamy Ukrainie. I tam sytuacja w Ukrainie jest bardzo dynamiczna. Już mówię tutaj o uchodźcach, w Polsce również, że to, co było potrzebne 2 tygodnie temu, nie jest koniecznie potrzebne w tej chwili. I oczywiście Polonia w Anglii bardzo szybko się zorganizowała i było mnóstwo datków fizycznych, właśnie darów, koców, poduszek, pieluch, różnych rzeczy, ale logistycznie jest to bardzo trudne, żeby to przekazać do Polski, bo to trzeba załatwić transport, kierowcę, przewieźć, to kosztuje, ktoś musi to załadować, ktoś musi w Polsce to rozładować, ktoś musi zrobić dystrybucję, a jeszcze jest problem taki, że że Anglia już nie jest w Unii, więc przewóz rzeczy z Anglii do Europy wiąże się z jakimiś przepisami celnymi i tu się robi duży problem, więc prosili, bardzo prosili, jeżeli ktoś chce dać i myślę, że wiele z was już dało, a kto jeszcze ma ochotę dać, to proszę dać pieniążki. I tutaj Tomek jakbyś wyświetlił to, przykleiłam na ścianie, to jest oficjalny plakat Donate i tu są różne organizacje takie jak Polish Center for International Aid, Caritas Polska, Polish Red Cross, UNICEF, Polish Humanitarian Action, Ocalenie Foundation. Te wszystkie organizacje są jak najbardziej sprawdzone. Proszę sobie przyłożyć telefon, zeskanować i możecie robić jakiekolwiek donacje poprzez internet. Jest to bardzo łatwe. Ile Państwo życzą sobie na którykolwiek z tych organizacji? Chyba to jest najprostszy sposób, w jaki można Ukrainie pomóc. Także w ten sposób chociaż możemy dołączyć, a będziemy mieć dyskusję z Agnieszką i z Elą na temat, w jaki sposób możemy się włączyć w te bardziej praktyczne sposoby pomagania Ukrainie. To jest chyba na tyle. Wspomniałam o skanowaniu, także tutaj jest skan, można sobie przyłożyć telefon. Jeżeli już nikt nie ma żadnych dodatkowych, Tomek, chciałbyś coś powiedzieć? Proszę bardzo.
Ten QR kod, który jest na ekranie teraz, to można zeskanować w swoich telefonach. Tu też na sali możemy, albo to zrobić teraz, bo za chwilę. I tam otworzy się wtedy taka krótka ankieta na temat dzisiejszego spotkania i jeżeli będzie wypełniona, to dostaniecie Państwo certyfikat od razu na e-maila automatycznie. Także można to zrobić teraz, jeżeli jesteście na Zoomie, jeszcze ktoś wytrwał i tak samo u nas na sali. Dobrze, Dorotka?
Dziękuję wszystkim Państwu za przybycie na nasze spotkanie. Bardzo ciekawy wykład, Agnieszko. Myślę, że rozmowa była bardzo interesująca i cieszę się, że wielu z Was też się włączyć chce w pomoc Ukrainie. Dziękuję również wszystkim na Zoomie. Nie wiem, czy oni jeszcze są podłączeni. Dziękuję ślicznie, że dołączyliście na Zoomie. Szkoda, że nie mogliście do nas dołączyć osobiście, ale mam nadzieję z wszystkim z Państwem się zobaczyć na spotkaniu w ambasadzie 30 kwietnia, przypominam, i nasz bal polski w Roehampton Club 21 maja. Serdecznie zapraszam i dziękuję bardzo. Zapraszam na lunch. Proszę bardzo się częstować. Mamy lunch w postaci bufetu. Także dziękuję jeszcze raz.
Tak, weźcie sobie, jak ktoś ma ochotę zobaczyć. Ktoś jeszcze ma ochotę sobie wsiąść. Ktoś jeszcze ma ochotę sobie sprawdzić, jaki cukier. A czy ktoś sobie zobaczył, jak się z tymi insulinowymi spróbowaliście sobie przyłączyć sobie. A to jest nie, to jest do wzięcia.
To jest ja mogę poprosić jeden?
Tak, proszę. Bardzo proszę. No. Także nie wiem, czy ktoś ma ochotę zobaczyć, jak się tutaj robi injections.
To jest po prostu igły się wsadzają.
Ja tutaj jeszcze, czy ktoś jeszcze jest na Zoomie tutaj? Staram się to rozłączyć.
Są jeszcze jakieś takie rzadkie rodzaje miałem takiego pacjenta, ja myślałem, że miał type 1, a miał variant. To jest związane z, że insulina nie działa, czy...
Są te mące, to jest tak, że masz te receptorami.
Tak, to jest co on miał, jak wysłałem, to przyszedł właśnie.
Ja też dziękuję bardzo wszystkim zoomowcom albo członkom, uczestnikom spotkania na Zoomie, i w takim razie już tu, jeżeli Państwo chcecie, to możecie, ja nie będę wyłączał kamery, żeby jeszcze chwilę działała, a jeżeli ktoś chce, nie wiem, porozmawiać z kimś, to zawsze można. Chociaż to teraz już jest tak głośno, że pewnie się za bardzo nie da. Super, pozdrawiam wszystkich i dziękuję za obecność. Pozdrawiam. Proszę.